a couple of things came up in the breakfast session. One of the concerns is that access to thrombopoietin receptor agonists. So it's a bit of a postcode lottery at the moment. So for some people who came to the room, they were able to treat patients with romoplostim or L-Thrombopag quite fairly soon after steroid use, but others, they were delayed for 6 months. And we certainly know from a survey we've done of the country that for some patients, actually, they can't access it for 12 months. So we had quite a lively discussion about that and how that's really quite unfair, and that it's not in line with guidelines. So many of the guidelines, and in fact, the German guidelines for ITP has recently been published, suggesting that we should be using TPOR receptor agonists really soon after steroid failure. And it's something we were able to do during the pandemic because NHS England allowed us to do that. But after the pandemic, they've gone backwards, and actually NICE has not yet reevaluated the use of L-Thrombopag and romoplostim and ITP. So it's a lot of frustration, I think, for both patients and clinicians. And also quite expensive because they might need steroids or IVIG treatment in and out of hospital. So it's something that we've been trying to address for a while, and I think it's something we certainly need to take back to NICE and NHS England for availability for medications. So that was a big thing. And then we discussed a few of the refractory difficult cases, use of genomics, use of immunoglobulin investigations and things. So I think that was the most of the sort of discussion that we had, really. Actually, the breakfast session led quite well into how to investigate and manage patients with ITP as to whether they might have an immunodeficiency disorder. So Siobhan Burns, who's a clinical immunologist and professor of immunology at the Royal Free Hospital, gave a fantastic presentation about which patients we should be doing further investigations in, and reminding us that patients with common variable immunodeficiency often present to hematologists with either ITP or hemolytic anemia. So measuring immunoglobulins, lymphocyte subsets is really important. And we also discussed the value of genomics testing, which I think is at the moment is quite a difficult place, but exciting and interesting. And certainly patients who have increased infections as well as autoimmunity, we should be doing the R15 panel, genomics panel, which is looking for immunodeficiency panel. I think that's something as a group we will be taking forward. I think Hani from Boston also talked about switching from thrombopoietin receptor agonists. We now have avatrombopag, L-Thrombopag, and romoplostim for use in patients with ITP. And actually, if you don't respond to one, you might respond to another. But if you do respond to one, you might not respond to another. So more confusing area, but interesting. And Matthias from Paris showed us some very interesting data about patients who fail rituximab, and actually that there might be certain memory cells or plasma cells in these patients that don't effectively respond to rituximab, and that we need to think about better strategies for those patients.